Welcome back to Across the Rheum, the official podcast of Rheum Connect, where cutting-edge science meets expert clinical insight in the field of rheumatology. I'm your host, Dr. Sergio Schwartzman, and we've reached the final installment of our three-part series, the IL-23 paradigm in psoriatic arthritis. In part one, we explored the immunological basis for IL-23 inhibition. In part two, we reviewed the currently available interleukin-23 agents and their supporting clinical trial data. Today, in part three, we'll begin to put it all together with a discussion on the clinical utility and positioning of IL-23 inhibitors, show how these therapies are being integrated into practice, how they compare to other options in PSA treatment algorithm, and what patient profiles may benefit more. Once again, I'm joined by Jessica Farrell, PharmD, and Dr. Monica Schwartzman, who have helped guide us through this evolving therapeutic landscape. Jessica and Monica, thank you for your contribution. Let's begin. But now, instead of me asking the questions, the two of you will take turns asking me questions.
All right, so let's begin with a foundational question. So where does methotrexate currently fit into the psoriatic arthritis management, particularly in the era of targeted biologic therapies?
It's a very interesting question. So I think if you look at all of the treatment recommendations, whether we're looking at the ACR, whether we're looking at the Europeans, whether we're looking at GRAPPA, methotrexate is viewed as a first therapy that we should be using in patients with psoriatic arthritis. And whereas I think that methotrexate is the first therapy in rheumatoid arthritis, I'm not sure that it is that effective in psoriatic arthritis. So being a little bit of a heretic, I would argue that perhaps it's time to move away from methotrexate. And I know there isn't a lot of agreement across the rheumatic disease community there, but I think we have to look at the data. And as such, there is only one published trial on the effectiveness of methotrexate in psoriatic arthritis. And this was a 6-month randomized controlled trial that actually looked at methotrexate versus placebo. And the outcome of this study was that there was no statistically significant difference. In further support of this is if I asked all of you what your placebo arm is in all of the clinical trials in psoriatic arthritis, the placebo arm is methotrexate. So here we have one study that showed no statistically significant difference, and the other studies where methotrexate is viewed as the placebo. So I've asked my question in my clinic as to why am I treating patients with placebo? And as such, I moved away from it. And I now start with a biologic agent. Now, there's a lot of criticisms of the MIPA study, including that it was a small number of patients, that the dose may have not been high enough. The mean dose was 15 milligrams. And in terms of the disease activity in these patients, it wasn't similar to the clinical trials. The mean joint count was only 5. Finally, there was a high placebo arm, but there's always a high placebo arms. Just one other study that argues potentially for the use of methotrexate is the SEAM PSA study. And that was an interesting study. I won't present it in detail, but it really looked at etanercept monotherapy, methotrexate monotherapy, and a combination of the two. And sure enough, statistically significantly, methotrexate plus etanercept was superior. But some of those who argue for the use of methotrexate state that the methotrexate response was not so bad alone in this study. And the answer is they're right, but methotrexate plus etanercept was better.
Okay, well, anti-TNF agents have been around for a long time and considered a major player in the psoriatic arthritis treatment regimen. How do you view their role today, given the emergence of newer mechanisms?
So I still very much respect anti-TNF agents. I grew up with them. So I think that they are indeed very effective medications. And as already discussed, we need more data in head-to-head studies. But as I look at the biologic agents and their use in psoriatic arthritis as first agents, I'm also evolving in my approach to these. And one of the pieces of information that drives me in that direction is treatment persistent across time. And this slide from Big Data is a summary slide that looks at anti-TNF agents, IL-17 inhibitors, and interleukin-23 inhibitors. And if you look at persistence over a 2-year period of time, you can see that there's relative overlap, but overwhelmingly, it's the IL-23 agents that are most likely to still be on board 2 years after they're started compared to their other class.
So I'll take over the asking questions of my dad for the rest of the presentation. Certainly, he asks me plenty questions throughout my life.
Not all about medicine.
Moving forward, how important is preventing radiographic progression in psoriatic arthritis?
There's been an evolution, I think, in my personal view of that question, and it's one that I've been struggling with over the last 5 years or so. When I started in rheumatology, we would take x-rays of our patients with rheumatoid arthritis and with psoriatic arthritis of their hands, sometimes their hands and their feet every year. Not really sure why we did that back then, because we couldn't prevent radiographic progression. But there is certain things that we have learned about radiographic progression. The first is that it can occur very early. Some patients may have erosive disease within the first 6 months of developing inflammatory arthritis. We know that once patients have radiographic disease, that there is a correlation with worsening HAQ scores, independent of inflammatory disease. A challenge that we have is whereas for rheumatoid arthritis, we do have a minimally clinically important change in radiographic progression, and that's a Van der Heijden score of 3 to 5. That has never been validated for PSA. So what then does it mean to have a change in the Van der Heijden score in patients with PSA is the question that I asked myself. And initially, my answer to that was less than 1, a 0.5 change. How important is that if we're looking at a meaningful change in rheumatoid arthritis of 3 to 5? And I think when I first thought about this, I didn't really carry that thought forward. But if we use one example of an IL-23 agent that recently did show benefit in preventing radiographic change in patients with psoriatic arthritis, called the APEX study. This was a study that included patients who had a high risk of progression. They had to have at least 2 erosions. And what you see in the data here is that the guselkumab-treated arm on the right in the bar graph progressed to approximately 0.5 sharp scores over 24 weeks. Whereas the placebo arm, remember this is a group of patients who have very active disease, was 1.35. So if I look at that, I start to question, does 1.35 modified sharp score make a difference in a patient? And if you ask it solo at week 24, we can argue about that number. But assuming, and clearly this is an assumption with a lot of caveats, that that progressive rate of 1.35 continues for the next 5 years in the placebo-treated arm, what does that then mean with regards to what that patient's sharp score will be in 5 years? And that number is 13.5. And I do believe that a modified sharp score change of 13.5 will have clinical implications in a patient who has psoriatic arthritis. Now, we still have room to go because in this high-risk group, even if you do that for the treatment arm, for the guselkumab arm, that number also goes up over time. So as I think about radiographic progression in patients who have psoriatic arthritis, I do think it's important. The last point that I'd like to make in closing on radiographic scores is that X-rays are time-honored and associated with disability. They're associated with worsening HACs in many of the inflammatory arthritides. Yet they are a bit outdated. And I think as we move forward in time, imaging will change, and the outcomes that we should be and we will be looking at are MRI and ultrasound.
So as we look to the future, how do you anticipate IL-23 inhibitors being positioned within the PSA treatment landscape?
So when IL-23 agents first became available, and this is now looking back at ustekinumab a decade ago, the one thing that impressed me about them and has played a more dramatic role in how I position agents is depicted in this slide. And this is a safety slide. So we've shown you that the IL-23 agents are effective across the psoriatic disease space as such. Why would I not use the safest medication class first instead of looking at medicines that have more adverse events? So as we look at the safety data to conclude the presentation today, what you can see here is that looking across classes, TNF inhibitors, interleukin-17 inhibitors, and interleukin-23 inhibitors, you can see that serious infections are more common with TNF inhibitors. The IL-17s are lower than the TNF inhibitors. And in the IL-23 space, they're very similar to placebo. TB is potentially a risk with anti-TNF agents, but I would argue strongly that it is no risk for IL-17 and IL-23 agents. Malignancy risk is debated back and forth with TNF agents. Is it the disease activity or is it the agent? But it's not something we worry about at all with interleukin-17 inhibitors and with interleukin-23 inhibitors. Autoimmune diseases such as lupus, demyelination, these conditions are potentially seen with the TNF agents. The only one we can discuss is IBD as a risk in patients who are treated with IL-17 inhibitors. And we know that these autoimmune paradoxical reactions do not occur at all with the IL-23 class. And pointing out here, difference in IBD may be slightly different for the IL-17 inhibitors, but both the TNF inhibitors and the IL-23 inhibitors are approved for the management of patients with inflammatory bowel disease. Immunogenicity is very low with the IL-23 inhibitors. It does exist with the TNF inhibitors, and it is low with the interleukin-17 inhibitors. So back to your question, I answered it perhaps in a way that you didn't expect, and that is that I've already told you that I'm moving away from methotrexate as my first treatment in patients with psoriatic arthritis. Likewise, I am now much more focused on the IL-17 class and the IL-23 class as first-line biologics in patients with psoriatic arthritis. And that's my positioning of biologic agents. I should also close by the fact that in this discussion, we really focused on the biologic class. We did not cover targeted synthetics, but these are yet another group of therapies that are making their way into the treatment of psoriatic disease. And for some, such as upadacitinib, have an established place, unfortunately, after TNF inhibitors. So I think before I take any questions, which I will, I'd like to close the presentation by telling you that what we've tried to do today is to give you a view of the IL-23 class from an immunologic mechanistic perspective, from a clinical trial in psoriatic disease, psoriasis, and psoriatic arthritis, and potentially, at least in the view of one rheumatologist, into where the evolving landscape of therapies for psoriatic arthritis hopefully will be moving towards in the near future. So with that, I will take questions.
So I do have a question also about access. So you mentioned that you often are starting with a biologic as opposed to, starting with methotrexate. Do you have issues with access? Since me as a pharmacist, I'm involved with helping my providers get these drugs. Have you seen kind of pushback from insurance companies to skipping methotrexate?
Surprisingly not. So it's been an education. I think at the very beginning, we've been doing this now 3 or 4 years that we've been skipping methotrexate, at least. And I think in the very beginning, we would get questions, have the patients failed or had an adverse event to methotrexate? We don't get them now. Mm-hmm. So access has not been an issue because of that.
Yeah. My trick is that since these are psoriatic arthritis patients, you can always use a psoriasis diagnosis, and they don't care about methotrexate for psoriasis alone. So you use the dual diagnoses. So
even though methotrexate was first used for psoriasis,
I know,
before psoriatic arthritis.
So my last question is related to some of the safety aspects that you brought up. So it looks like there potentially is a signal for worsening inflammatory bowel disease with the IL-17 inhibitors. So it's a patient population that we might avoid using that class. And earlier, Monica talked about the downstream effects of IL-23 inhibition affecting IL-17. So do either of you have any theories in terms of why, with the IL-17 specific, we see that safety signal of worsening inflammatory bowel disease versus we don't really see that signal with the IL-23 inhibitors?
I can take that question. So we have data from mouse models that one of the proteins that's responsible for maintaining the integrity of the intestinal barrier is IL-17 dependent. Therefore, by inhibiting IL-17, we are compromising the integrity of the intestinal barrier in the gut, which is a potential hypothesis as to why we see inflammatory bowel disease in patients treated with an IL-17 inhibitor. As we discussed in the first episode, there is an IL-23 independent production of IL-17 pathway through the innate immune system. So a potential hypothesis as to why the IL-23 therapies do not lead to de novo IBD is because we maintain some IL-17 production through that pathway.
Very helpful. That makes sense.
So I'm going to wrap up with one last question. So we've covered a lot of ground over the last 3 episodes, both from a basic science perspective, from a structural and medication perspective, and lastly, from a clinical perspective. So what's next in the IL-23 space?
I think it's not so much the IL-23 space. I would probably expand that. We are looking at oral molecules for the management of psoriatic arthritis. We're looking at IL-17 therapies, nanomolecules that you may be dosing once every 6 months for psoriatic disease, as opposed to how frequently we are. But I'd like to kind of expand that question. And looking at the near future, what can we expect in the next few years in the psoriatic arthritis space? So I think the first area of interest that we didn't cover in detail today, but was mentioned, was a concept of axial psoriatic arthritis. Is that a different disease that's more in the psoriatic arthritis space than what we term axial spondyloarthritis, which is more in the ankylosing spondylitis space? And I think that question, to some extent, will be answered by a trial that's looking at an IL-23 agent in patients with axial psoriatic arthritis. I think the other thing, the next thing I should say, that we should be seeing much more information on, and we've seen it now at least the last 3 to 4 major meetings, is combination therapy. And I think many dermatologists and many rheumatologists are combining therapies to manage their patients with recalcitrant disease. But there's not been a really unified approach to this. Again, there's a study that's looking at golimumab plus guselkumab for the management of psoriatic arthritis, and that will give us information. But I'm sorry to say, it's only going to give us information for 2 classes, whereas what's happened in the field are that rheumatologists and dermatologists are combining almost every potential combination that you can think of. And there are series that have been published on this, but I think we need to unify that approach to it. The last piece, and I think that you touched on it, was this difficult to treat group of patients with psoriatic arthritis. They are clearly out there. They clearly exist. And if we look at the prevalence of that group, it's very dependent on how you define the group, but it could be anywhere from 5% to 20% of patients with psoriatic arthritis. So I think we need to unify a definition of D2T patients, the complex patient who, as you mentioned, may have fibromyalgia or osteoarthritis that's driving their disease, where we should not escalate treatment, and the patient group who has recalcitrant disease, which is inflammatory musculoskeletal disease. Frequently, these are the patients with severe enthesitis that we can't manage with anything else. Once we come to a formal definition of those 2 groups, then clinical trials should address that phenotype. And I think in the immediate future, those are the things that I would expect in the psoriatic arthritis space. So I think with that, in this final segment, I'd like to thank both of you, Jessica and Monica. I think you did an outstanding coverage of the questions that were asked, and that you asked me appropriate questions, honestly, some of which I didn't expect. So thank you all, and we hope to see you in the future as we will continue to have podcasts on different topics. We'd also like to extend our sincere appreciation to RAP for cross-posting this in Rapcast and in the Arthros website, and to Johnson & Johnson for providing their continued support. I'm Dr. Sergio Schwartzman, and thank you all for listening.